to highlight the collaboration which was ongoing over the last 30 years or so, almost 40 years now, actually. I thought we'd show 4 examples of things that we've learned and how we use imaging and fetal therapy, some very invasive, some less invasive, to highlight our collaboration. The 4 examples we'll look at are fetal lung masses, congenital diaphragmatic hernia, fetal myelomeningocele, and monochorionic twin syndromes, including twin transfusion and a twin reversed arterial perfusion. We'll talk a little bit about the contributions both that we've made with the better imaging of these defects, allowing better understanding of the pathophysiology and natural history, and also how we've used ultrasound in invasive therapy and the benefits of invasive therapy. And the first one is the lung mass or congenital pulmonary airway malformations. These are, in the fetal life, usually cystic adenomatoid malformations and pulmonary sequestrations. And I have to say, when we first started looking at these, almost all the cases were considered surgical candidates because they were in dire straits. They were large lesions. Most of the fetuses had Hydrops fetalis, which is a sort of decompensation where they have ascites and skin thickening. If you have a lung mass and Hydrops, there was nearly 100% mortality. And if you had a lung mass and no Hydrops, there was almost never any mortality. And that highlighted the importance of Hydrops. At one point, we believed that solid masses did a lot worse than cystic masses in the chest. We no longer believe that. In fact, we now firmly stand behind that observation that Hydrops is the great segregator among the fetuses who are going to do okay on their own compared to those who are not going to do well. And we know that only large lesions produce Hydrops. And to try to estimate the size of the lesion, even though most of us who do ultrasound could just look at a sonogram and tell you whether we think the lesion is large or small, we worked on a semi-quantitative assessment of lung masses, and 2 were produced and are used today. Probably most commonly, Tim Krummelholm's CVR, cystic adenomatoid, or CCAM volume ratio, which is a volumetric measurement of the lung mass compared to the head circumference, and a little later produced a paper on just a simpler measurement, which was considered the mass-thoracic ratio, which just measures a single measurement of the lesion compared to the thoracic transverse diameter. And that also helped us very importantly study the natural history of these lesions and recognize that, in fact, now we could see a lot of lesions in fetuses who weren't in such dire straits, large lesions, small lesions, medium-sized lesions, but the important observation was that the natural history had not been really recognized, and the natural history is that as gestation progresses, 30 to 50% of these lesions either stabilize or get smaller on their own without any therapy at all. And this is true even of large lesions, and that enters the proposal by Sam Hawgood that maybe this has something to do with maturation of the lung mass. This is a very important way that our conversations in the Fetal Treatment Center and the Fetal Treatment Conference that we have every day actually generated something that really works.